It used to be that getting the right patient to the right doctor, getting the right care at the right time, didn't seem so complicated. That was before the tremendous progress that literally has been made in helping people live better. Not necessarily longer, but better. And so when you think of reputation, this is a great slide from Henry Ford. There is really no adequate measure for reputation, but as he said, you can't build a reputation on what you're going to do. The other day when I spoke on the opening plenary, the fact is all the small companies, and as we were one, boy, you know, to get started, to build that reputation, it was a long road to get it to where we were proven for what we could do. So it's not that unlike small hospitals. So to enhance reputation, you must be first doing something well. Second, other people need to notice your efforts. And third, they need to believe that it benefits them. According to the American Hospital Association, the AHA, there are nearly 2,000 small or rural hospitals that are located outside the metropolitan statistical areas in the United States. Nearly 1/4 of the US population lives in those rural areas. Rural communities, as you know, rely on their hospitals as critical components of the region's economic and social fabric. Often, they are the largest employers in their communities. A strong healthcare network adds to the attractiveness of a community as a place to settle, raise a family, locate a business, or even retire. These small and rural hospitals are defined as having fewer than 100 beds and less than 4,000 visits or admissions annually. Although the AHA, the American Hospital Association, doesn't provide information on the financial well-being of these small acute care critical access hospitals, most are struggling to stay in the black because they lack the resources to absorb the reimbursement pressures facing the industry. In fact, in a recent article penned by Lisa Goldstein, a Moody's analyst, she says almost all rating downgrades were small-sized providers, continuing a trend that has been seen for several years. During the first quarter of 2013, 5 of 6 credit rating downgrades were of nonprofit hospitals, the smaller hospitals, Moody's reports. Most acute critical access hospitals can offer only emergency medicine and primary care. Few have any specialists available on staff. They tend to rely on a few key positions. How many people here in this room are part of a small rural hospital acute care? And anyone? Higher? No one? 1, 2, a few. So you know what I'm talking about. So in these small acute care, critical care access hospitals, they have limited leverage, and you'll relate to this too, in negotiating with commercial payers and vendors because of the low patient volumes and lack of economies of scale. Many have large Medicare populations, which funding is at risk of being cut by the federal government, as you know. Rural residents are often uninsured and have lower incomes. To keep pace, there is a pressure on small hospitals to invest in modern equipment and to renovate aging facilities. Again, if this makes any sense to those of you in that situation. Before these small hospitals may be able to upgrade, small hospitals could be the first, think about this, could be the first to deal with the greater patient demand created by the Affordable Care Act when millions more will be insured. They've been coming to the hospital, but now that they have insurance, they may come a little bit more frequently. Many patients are transferred, as you know, to larger hospitals in urban areas for care, and thus the small community hospitals lose out on those bed revenues. A recent study in San Diego found that small hospitals engage in secondary over triage quite often, and especially so with pediatric patients. And Dr. Nicholas, you maybe can echo that later after some questions. But basically, patients are transferred at a higher rate. The young patients are transferred at a higher rate than the older ones, because they don't want to, the EDs don't want to get it wrong, and they do so in a precaution. In emergency situations, patients are sent by air evac helicopters and ground ambulance to that higher level of care. It's very expensive. Yesterday I was talking with Gigi from Flagstaff, Arizona, at the Flagstaff Medical, and every time they bring in a patient off of the reservation via air evac, it is a $14,000 air transport. And so often, that patient is released in the next 20 to 24 hours because they really didn't need to be at that level of care. People who live in these small communities are aware of the limitations of their hospital, so often that they drive past that local hospital to the nearest higher level hospital, usually in the urban area. So I want to talk about a couple different situations, 3 in particular. The Copper Queen Hospital, located just 2 miles north of the Mexican border on the very southeast of Arizona, is 85 miles away from the larger hospital in Tucson. Their CEO was worried about the bottom line of their hospital, and he began investigating the use of telemedicine in 2009. It took them about 6 months. They went through all of their different vendors. They went through all the vendors, looked to see what they could find, and they partnered with Carondelet Health in Tucson to deliver cardiology. In the first 6 months, they actually took records of first 6 months of delivering cardiology. 36 patients were presented with cardiac issues. In the past, they always sent all 36 patients to Tucson at a cost of about $10,000. But in that first 6 months, with the use of telemedicine, what they did, they were actually able to retain 27 of those patients, provide them with heart monitors or medication. They did not have to transfer them. They saved literally over $500,000 in the first 6 months of utilizing the technology. According to Jim Dixon, who is the hospital's CEO, word spread quickly through the community that their local hospital could now treat, or at least triage, patients appropriately for heart problems. Made a big difference in their community. In fact, Dr. Daniel Rowe, the director of Copper Queen's emergency department, says the cost of doing 1 transport, he can literally do 70 to 80 telemedicine consults. So on parity, 70 telemedicine consults, 1 unnecessary transport. Their new mayor, Adriana Badal, says that their whole community has started to revive. Patients know, the people in the town understand and know that they literally have proper care, because Copper Queen didn't just stop with cardiology. They added neurology. They added dermatology, pulmonology, trauma, and the latest thing that they brought to Copper Queen in Bisbee is burn. And so what they've been able to do off of one system is add all these different modalities and really are changing the paradigm of the small hospital in Bisbee, Arizona. In fact, it's so successful that they led the formation of the Southern Arizona Telemedicine Alliance. They also pushed for legislation in Arizona that we just got passed for parity for a telemedicine visit as well as an in-person visit. So they've been very successful. I put this slide up just because in neurology, there's so many stories I could tell you about successes with neurology and failures in neurology when there wasn't telemedicine, but time is brain. And so I always like to throw that into my presentations. Let's switch to California. In northern Nevada, just next to California, there's a healthcare system called Renown. Renown has a coverage area about the same as the state of Kansas, 800,000 square miles. They really only have the small hospitals in those areas, but Renown has been able to add the service lines for telemedicine into those small hospitals. It has been extremely successful, and versus hours of driving to get to the proper primary care or specialty care, these patients in these rural areas are getting care right there at their local hospital. The estimate for an average visit for specialty care for any of those people living up in that northern Nevada area is between $800 and $1,100 when they computed time lost from work, mileage, meals, and all the other parts for daycare and everything else, just so they could get care for specialties. The next story I want to tell you about is the VA. So we have been blessed as a company to do a great deal with the VA across the United States and outside. The VA has had, in the past, only 154 hospitals. Only 154 for their entire patient population. Often driving to the hospital to get care sometimes was an overnight event for those living in rural America. So the VA realized with the aging population of 850,000 living World War II vets and many more in the age of 60 and 70 for Vietnam vets, that literally they had to do something because their costs were going to exceed all expectations. So the VA did some studies about 5 years ago and decided that telemedicine literally could help bridge that gap. They could provide the best care, they could lower their costs. And so the VA has now in place 851 community-based outreach centers, community-based outpatient centers. They call them CBOCs. Those 851 locations have changed the value proposition for vets. They can actually be seen within most of them can be seen within 25 miles of where they live. The VA has reimburses, by the way, for their mileage and for their meals, and if they have to stay overnight. But with the CBOCs in place and telemedicine and these patients being able to be seen by their doctors, literally the VA eliminated the whole copay system for any one of the US vets being seen through the technology. The VA has realized significant gains. And when they have queried, like Dr. Nicholas, on patient satisfaction, it is at the highest level of the patients are so pleased with the availability of quality care in their backyard. When you look at the reputation of these facilities in the small towns, literally, as I said, patients would drive past their local hospital to go to the larger urban area to get their specialties. Both in the Renown area and in the Copper Queen area, patients are coming back to live in their areas. Businesses are coming back. This is what we're told because they know they have the quality of care that they need. They don't have to live only moments outside of a hospital or their specialty care providers in the urban areas. So the challenge we face today is not merely starting, that you face, and all of us do, is not just merely starting a telemedicine program, but really getting the word out to the community that programs exist and that you can receive the quality of care that you would normally get in a high urban area. So thank you.